Good morning, everyone. Nice job. My name is Casey Kelly. I'm the Chief Innovation Officer of the Meadows Mental Health Policy Institute. And at the Institute, we are unique in the ecosystem in that we operate at the intersection of policy and programs at the state and federal level. I'm delighted to be here facilitating this panel, and I hope you guys realize that you are in for a treat. I just want to say thank you to Behavioral Health Tech and to Brightside for inviting me to facilitate the panel. And I'm really looking forward to hearing from these great experts today about such an important topic. In case you can't read the screen, today we're going to talk about bridging the gap, leveraging technology to treat high-severity mental health patients. I do want to just acknowledge that some of the content today that we're going to discuss involves suicide. And I just want to make sure folks are aware that sometimes that conversation can be upsetting or triggering. So feel free to get up and leave if you need to. But we are excited about the topic and look forward to talking about the solutions involved in identifying folks who may be at risk and may be struggling. So effectively treating the most severe mental health cases, including those that may be at risk of suicide, is really key to solving some of our most complex mental health challenges that we have across the country and across the world. And these include populations who may not have access to a lot of resources. And that's why specialized care is really, really important. And unfortunately, specialized care is not always available to populations most in need. And so we're also going to talk about the ways that tech-enabled solutions might be able to help extend our workforce, optimize our workforce, and bolster the overall ecosystem to make sure that more people have access to high-quality care when and where they need it. So I'm going to introduce each of our panelists so that you know a little bit about the depth and breadth of expertise you have here on the stage. So first we have, actually, I told you guys you could sit wherever you want, but my order is a little different. So let's start to my right with Ann O'Grady. Ann is the Behavioral Health Director of Independence Blue Cross. And there she is focused on access to quality care, measurement and value-based care, program development, and program partnerships. Next to her, we have Brad Kedrich, who's the CEO and co-founder of Brightside Health. Brightside Health, in case you're not aware, is a national telepsychiatry platform that supports over 130 million lives across commercial, Medicare, Medicaid, and exchange plans, specializing in underserved and hard-to-treat populations. Next to Brad, we have Cara McNulty, who's the CEO of Vibrant Emotional Health. Vibrant is a leading health, Cara is a leading health scientist championing mental health access and reducing stigma in high-risk communities to drive impactful change and improved behavioral health outcomes. And then rounding us out is Dr. Caroline Carney, who's the president of Behavioral Health and Chief Medical Officer at Magellan. Magellan is an organization providing clinical programs directed at the country's behavioral health needs and management services to health plans, states, employers, and federal agencies. Can we just give a quick round of applause for our panelists? Thank you. I'm glad I didn't have to ask you guys to do that twice. All right, so to begin with, I'd love to hear from you all just a little bit of level setting about the current landscape for individuals with severe mental health needs. Cara, could you kick us off and speak on the state of care for those facing complex and acute challenges?
It's always good when your co-panelist says, I think the mic's on. And I'm batting it around. Yes, I can. So I'm a population health scientist, and my kids would say a total nerd. but I've had the fortunate opportunity to work on the federal and state side of behavioral health, the employer side, the consulting side, the payer-provider side. Sounds like I leave jobs quickly. I don't, just aging. And now a nonprofit side. And we all know that the mental well-being of our communities needs work. So if you just think about some basic facts, Vibrant Emotional Health is a national provider of lifelines. We are the back end for 988. So in 2 years since 988 has been enacted, there have been 11 million interactions, phone, text, SMS, call. 11 million. Of that 11 million, 98% of those engagements are people who aren't in imminent risk. They are seeking support before imminent risk. So just think about that in our ecosystem. And they're looking for, where do I get care? What am I experiencing? How does this work? My Chief Technology Officer, Grant, where are you? He's right here. Grant just told me as I was walking in, and we won't get into the politics, but since 2 a.m. last night, our crisis line, our lifeline, has doubled in calls, and it's expected to triple by the end of today as a result of just our communities trying to figure out what's next. The other thing I'll say is we know that people have underreported not only mental health issues, but serious mental health issues. So 28% of adults with serious mental health issues say they have a terrible time, not a hard time, a terrible time seeking care or getting consistent care. And then if you're an adolescent in any fashion, young adult, 1 in 4 have thought about self-harm, post-pandemic, pre-pandemic, and through pandemic. And then if you're a population, Black, Brown, LGBTQ, who also has a serious diagnosed mental illness, you're feeling isolated. So there's a lot of work we need to do. All that to say, hot dog, there are great people on this stage that are going to talk about what we're doing to improve that.
Thank you, Cara. Those are sobering statistics. Brad, how does that sit with the work that you're leading, and specifically underserved populations? And can you share a little bit about the current state from your view?
Yeah, good morning, everyone. So great to see you all here. I think Cara covered a lot of the stats that we all are aware of, and some of the alarming trends and the forces that we're really trying to work against and change. I think the observation we have and the perspective we have is that we talk a lot about access problems in mental health. And in doing so, in sort of talking about it as one-dimensional, I think we fail to account for the specific needs of certain subpopulations and how much harder it is in those subpopulations. And so, we fundamentally don't believe that mental health care is a commodity, that an appointment slot is an appointment slot, and what we need is just more appointment slots to solve this problem. When we talk about these populations that are certainly at these higher ends of severity and acuity, but then when you factor in subpopulations that may have specific needs, like teens or people with substance use disorder, what you need are levels of subspecialty care with specific training and specific tools and protocols, not to mention the access to be able to support those needs. And then, of course, you've got to overlay that with the payer coverage and people's ability to access and afford those within their insurance networks, which we know, of course, is a pervasive problem. So you can, in this subpopulation, you can take the challenges we talk about as it relates to access and in many ways sort of exponentially multiply them. If you're a teen with suicidal ideation, on Medicaid or with a substance use disorder challenge, trying to find care is extremely challenging, right? It's hard enough to find a routine outpatient appointment, let alone a clinician who's specifically trained to manage and reduce suicide risk. And so insurance support is critical, specifically trained and tailored clinicians and tools available for these individuals is critical. And it's a part of the market we believe is just not talked about enough, not recognized enough, and not invested in enough to be able to support these critical needs. And of course, that ends up perpetuating the problem. We've got more people showing up at the emergency department. We've got high readmission rates. And I think we all know that is one of the worst places to receive mental health care. You really don't receive care. You receive stabilization and triage, but it ends up being a perpetual cycle, and we need to break it. I think we can all agree.
Thank you. Yeah, one of the things that we talk about at the Institute is that in the current state, most mental illness is diagnosed in the emergency room or in our justice system, unfortunately. Caroline, I'd like to bring you and Anne into the conversation. From a payer perspective, what challenges do you see with providing effective care for individuals, specifically individuals who are Medicaid beneficiaries?
Thank you. Thanks so much for all of you for showing up and for doing this panel today. I have a little bit different perspective probably than many of you might think I would come from. I'm an internist and a psychiatrist, and I have grown up in both worlds of caring for patients and seeing systems of care. So I want to walk you through what it's like for a person with serious mental illness with their first episode. If I'm a young man, say 22 years old, and still on mom and dad's insurance, I will likely show up in a student health clinic, or I will show up in primary care somewhere with care and treatment that those providers, frankly, don't know how to do well because they don't see it and they're not expert in that area. It's like having someone with a severe endocrine disorder show up in family medicine and they don't know how to take care of that, so they have specialty services to refer to. I may or may not get the right care. I may bounce around a while before I find my way to often a university setting where centers of excellence in first episode psychosis exist. If I'm a kid on Medicaid and I'm presenting with my first manic episode, I'm going to end up in the ER first, maybe a local community clinic, and I will for sure, as Brad was saying, be bounced around the system until maybe I will have the good luck to land in a first episode psychosis program, if I can ever get there. I'm bringing this up because I don't think that we should care for serious mental illness based on the type of insurance that we have. We need to create systems of care that look at the diagnosis, the treatment, the right kind of protocols for individuals, and create those systems of care that can then support that. In my internal medicine world, I once participated in an organization called the Hoosier Oncology Group. And this was a group that took individual practitioners, oncologists and hematologists throughout the state, including rural areas. And they were all connected to the university setting so their patients could be enrolled in clinical trials. They could round with the experts. And these were specialty doctors, but the system was created that it didn't matter what the person's insurance was. It didn't matter if they hit the system in a rural town or at the university. They all got aligned to the same correct models of care. And while insurers may pay for those differently, I think from a policy perspective, we have to start getting that all aligned to the same way so that the bundle of care is paid the same, whether it's Medicaid or commercial, whatever it might be, it's paid to award the right kind of care being given.
And thank you, and thank you for walking us through that that patient journey and really grounding us in that experience. And I want to invite you to chime in here because you're thinking about the Medicare population often, and can you talk a little bit about your lens from that view?
Yeah, I mean, I echo Carolyn's perspective around the systems of care, whether it's Medicare, Medicaid, or commercial. it's far too difficult for for members, people to find care, whether it's for suicide, substance use. We don't have a system currently that enables people to understand sort of what competencies a provider may have and whether they are equipped to provide the specialty care that someone may need. And even in the physical health setting, I find consistently that physical health providers are saying that they're not screening for mental health issues simply because they're not clear where to actually send someone. And we really need to change that. I think many payers are working on care navigation systems at IBX. That's a very big focus, where we are building out sort of evidence-based therapies to be able to respond to triage, to assess, and to be able to get people to the right providers who offer the right skill set, qualifications, experience, and can deliver the evidence-based treatments that people need. Just sort of echoing kind of what's been said around, population health. I did a stint as a volunteer on the crisis text line, and was really struck by the kind of variation kind of in the population. Many of the texters were young people, kind of in their bedrooms, suicidal, simply because they had not met expectations of parents or schoolwork, et cetera. And then on the other side, kind of the older adult population, 40% kind of lonely, 37% socially isolated, and needing connection, human connection. And so I think that we really have a crisis of loneliness, sort of outside of, I know the Surgeon General's talked a lot about that, but I think, as Cara said, that really is playing into kind of aggravation sort of the already kind of deep anxiety and serious mental illness that's out there.
Thank you. It reminds me of a conversation Cara and I had recently about sort of shifting the conversation related to access to accessing care, and it's a minor shift. But sometimes I think we talk about access as if it's a single point in time challenge. And it really resonated with me. I've been thinking about it since we had that conversation, and sort of moving towards like our challenge of accessing care through a continuum. And I'd like to stick with you a little bit. So beyond this current landscape that we have of challenges associated with accessing care, what are the most important problems within your member base? And how can specialty care and technology, how can technology for specialty care help you achieve the goals that you're envisioning?
Well, I think the problem that we're talking about, that we, for far too long, have not been able to offer evidence-based therapies. We've not had visibility to an understanding of clinical models for people with serious mental illness. And it's been difficult to deliver them at any scale. So if you have a population, a commercial population, and there's often geographic challenges in meeting kind of the needs, people that live in rural populations, people that don't have access to internet, people that don't have access to transportation. So really finding kind of solutions that are going to meet the needs of the population are significant. And so in what I really appreciate about the tech-based providers, that they come with evidence-based, many come with evidence-based clinical models, specifically for populations with kind of a service set that is designed to meet the needs of the population that they're serving. And that makes it a lot easier for payers. I do a lot of data evaluation and analysis and looking at what services do we need for what populations and where, and what do the populations need. So that really has been, I think, a game changer in in being able to then deliver to our membership, whether it's through our care navigation team, whether it's through a digital routing process, get to be able to really support members in getting to the right quality care.
Thank you. And Caroline, what are your thoughts on how payment models might be able to incentivize or ensure subpopulations actually get the kind of quality care they need?
I think we have to look at payment models that support episodes of care and outcomes from those episodes of care. But to get there, we have to first be able to define what an episode of care is and what those quality outcomes might be. So I'm going to stick just with the first episode psychosis example for the simplicity of today. So we know in persons with early psychotic disorder, we're talking about SMI in the panel, that it's more than medication treatment. It's early medication treatment, but it is also therapy, and it is also coordinated social system of care for those individuals and supports for their families. So in an episode of care model, we have to look at how all of those come together and not have one provider over here prescribing something and another over here, or the ER prescribing something else, and therapy happening over here and nobody doing social supports. I'd like to look at how we bring this together in team-based care. And I do think that in the Medicaid world, we see models that frankly are much better than we do in the commercially insured world or coverage for the exchange population. We see those coming into community behavioral health centers where we can find the multitude of services necessary to wrap around those individuals. And even in federally qualified health systems, we're seeing more of that happen. So I would love us to be able, from a policy perspective, a payer perspective, and a provider perspective, get together to figure out what are those episodes, what are the important process metrics inside those episodes that should be met. It's not a 7-day follow-up. It's not a 30-day follow-up. There's a lot of things that can happen in those episodes that will ensure getting good care. So when we describe those, I think the payment models become really easy. If provider groups come together, team-based fashion, we can pay, call it a super DRG model of some sort, but something like that for those episodes of care. And where there are holes in those systems, can't come together in the most remote areas, the most rural areas, how do we go back to that first model of bringing those individuals in under the hood of technology and under the hood of collaborative care models so they can still participate in and get the right kind of episode?
I love the call to action to get more precise in how we're thinking about the different types of interventions and the different levels of care, as opposed to, I think sometimes we fall prey to putting it all into a single box. Brad, I want to pull you in here. From your view, how can technology really help us addressing the needs of our specialized care population, and specifically reducing ER visits?
Yeah, unsurprisingly, there are a lot of layers to that question and to the answer in our perspective. Obviously, you have to think about the patient as a core orienting factor, but of course, the provider and the setting that they're coming from, as well as the payer and their incentives and the things that they are focused on. So starting with the patient, of course, we're talking about individuals that are at one of the worst moments of their lives and really struggling. And so sort of the ability to make thoughtful, thorough choices and follow through is very limited. And so you've got to be able to meet people where they are, to ease that transition, to stick with them, and to give them lots of points of entry, to extend a hand and have them feel at the very beginning empathy and support and hopefully a sense of relief that they're getting to the right place and a sense of confidence. Of course, you also need to be able to accept their insurance, though. Again, like if you can't accept Medicaid or exchange, we're leaving behind the sort of probably biggest portion of these populations. And so having that broad payer coverage and that alignment is really critical. Obviously, we know that's challenging in a lot of ways, in a lot of places, the way that rates have been benchmarked. And unfortunately, one of the challenges we see is that the rates for treating these populations we're talking about are generally the same as the rates for a routine mental health encounter. So we've got, unfortunately, a little bit of sort of oversimplicity here that's making it hard for the type of incentive alignment we would like outside of very basic measures like 7 and 30-day follow-ups. And so, getting patients in, of course, getting them the right care under their insurance, and to Kara's point, ensuring that's through an entire course of care and a care journey, not a transactional, one follow-up care to hit encounter to hit a HESIS measure, and then sort of wish them the best. Back to the provider and their incentives as a referrer, I think from all the providers we've talked to, and if we look at sort of behaviors as indications of priorities and incentives, health systems don't like mental health encounters at the emergency department. It takes them, about 3 times longer to move a mental health patient through the ED. They lose 2 bed turns, and it's really hard to discharge those patients. So you've got people often, staying for days in the ER. You've got overwhelmed discharge planners trying to find places, giving people a list of providers and saying, good luck, I hope one of these can take you, and they end up back in 30 days. What those providers want is a highly reliable and easy consolidated place to send those patients so they don't have to go down these lists and make lots of phone calls, et cetera. That means somebody that's got the clinical rigor they can trust, that can do integrations with their systems, that has broad payer coverage to match their patient population, et cetera, and can take that pain off of them and make it easy for them to be able to move those people through and reduce that readmission rate that we've heard of around 14% in 30 days. So as a provider, being able to pull those things together is no small task. Obviously, it's hard to do any one of those things, but we've been very focused on building a set of tools and services to be able to address that very focused pain point, and do our best to be the provider that can solve that and bring the overlap for all those stakeholders together.
That's great. I think that really hits on a lot of what we hear at the Institute related to providers really want to spend more time providing care, right? And so the way that technology can help them do that and enable them to actually do and perform at the highest and best use of their skills and license, I think will really help us address some of the challenges you guys have been talking about. And I saw you raise your microphone like you wanted to contribute, and then I'm going to come back to Kara with a follow-up question.
2 things that I think are so important about what the digital healthcare companies are doing, especially for serious illness. One, including non-clinical services like peer support, and 2, in-between session support or 24/7 access. So many of people with suicidal ideation, chronic suicidal ideation, or intermittent or serious illness need to be able to reach somebody kind of at any time of the day, and the nighttime is particularly difficult. So I think the digital companies offer that expanded service that really has been very, very helpful, whether it's in kind of a child service where parents are reaching out at night when they're having a hard time with a tantrum and trying to manage that tantrum, or whether it's for somebody that's suicidal and the member actually has somebody to reach 24/7. That's the difference in a member being able to be stabilized in sort of a crisis intervention encounter versus going to the emergency department. And I think that's a really important value kind of for whatever the type of population, Medicaid, Medicare, commercial.
Very good point. And Kara, I do want to toss it back to you to hear sort of how you're thinking about the ways that Vibrant might be able to, or maybe already is, leveraging technology to help overcome some of these barriers that we've been talking about.
Can I answer that in a second? I just want to follow up on something
Caroline
Caroline
said, of course.
I came from before Vibrant, CVS, Aetna, and having been in that part of this ecosystem, that's the hardest job I ever had. So I give my counterparts here just unbelievable kudos for their efforts. One of the things I would say that you said, and I just want to echo, is that nobody takes the job that Caroline took or that I had because you want to deny service. Nobody. Like, that's the last thing you want to do. And so how do we, as different sectors, come together to look at payment models, to look at bundles of care, to look at quality outcomes so that that individual gets the right care at the right time in the right provider ecosystem? Because until we do that, it just becomes super easy to blame the payer. And stepping out of that, I mean, I feel like I had my own mental health, like, whew, because it's so hard. So that's just one thing I would follow up there. And then,
So, Car, can I just follow up and ask you, like, what do you think is preventing that conversation from happening? Like, how do we actually move past the silos?
yeah, I don't think anybody intentionally is like, oh gosh, we're going to say it's the payers, or we're going to say it's the providers, or the system is so complicated and it's bifurcated. And I can only speak from my time at a payer. We did not have the technology to connect these unbelievable digital providers at all times to our patients in need. And I don't think that Aetna CVS was the only one, and I have been gone for 6 months, so they may have made radical tech improvements. But the tech ecosystem, so that's why we talked about accessing care, because I think it's also becomes really a crutch for us to say we don't have enough providers, we don't have enough providers, we don't have enough providers. That's true in pockets, in areas, in specialties. But we don't have the railroad of tech infrastructure to make the process for care easier. And so I love tech-based solutions, and this is an incredible solution right here, dealing with serious mental illness with Brightside. And we have to figure out a way not to make it so the individual who's in crisis has to do absolute gymnastics and become a neuroscientist and, figure out how they get themselves to care, and they don't even know what kind of care do I need, do I have coverage? So we have to be able to not only advance the technology and continue to invest, but have the common outcomes, have better payment models, and collectively sit together as different pieces of this industry to make it work. And I think what trips us up is we all have goals to meet, we all have timelines, we all have funders of some sort, and our own economy of trying to get to the next goal line gets in the way.
Can I just say amen?
Yes, you can.
Okay. Thank you. So what do we do? As we're starting, Caroline, do you want to chime in? Do you want to respond? Yeah.
I'm dying to respond to this. I think what we're seeing in fragmentation is the fact that we have highly segmented payer organizations, all of which have different rule sets. Medicare has a different rule set than 50-plus Medicaid rule sets, then name your commercial policy rule set, and so on. And that has to be leveled. We have to have the same expectations and the same kind of payment rates no matter where it's coming. We go back to what I said at the beginning, think about the person and the diagnosis, and not having differential sets of care. And to reduce fragmentation, we need to be able to have groups like Brightside be able to be part of the system of care and not functioning independently on the side. So what are the models that we can do to use the right kind of technology and the folks who have the right kind of training and support into the ecosystem and not functioning just as an app-based service on the side? It will continue the fragmentation if we do that. So I think we have to think holistically around those how we think around the edges, but we have to clear the playing field. It is not ever going to work if folks in DC or a state capital say this is the policy without understanding the payer community, the patient community, and the provider community. We have to be at the same table.
I love that. I like to think about it as that sort of ecosystem of, that mosaic of solutions that we really do need to be thinking about, as opposed to a single solution at any point in time or any point in geography. So today we may be especially thinking about the future and the role that policy does play in our healthcare system and mental health services specifically. And I'd like to spend a few minutes at this point really talking about what you're hopeful for the future, and how policy may support the things that you're hoping we can achieve in the near and longer term, so that more people can access these great services that y'all's teams provide. So, Cara, will you kick us off, and then we'll move down the line, and then I'll also just invite the audience, if you have any questions for us, please use the app. You can, I think, there's like a QR code that's going to be up here at some point. Tech support.
Or we can do old school Q&A. There are mics here, so that
There
should be
are
fine,
mics
too.
here. Thank you,
Feel
Brad.
free to shout it out.
The light is so bright in my eyes, I actually did not see the mics. So thank you. So yeah, if you have questions, just come up to the mic. That'll be easier for me anyway as the moderator. But right now, let's spend some time really talking about what you're hopeful for and where there might be policy change that could support those objectives.
I'm hopeful about a ton of things. I'm hopeful that we sit here and have these conversations and we don't all agree, but we were talking about when you have breakdown, you can have breakthrough, that we get to the breakthrough. I am really hopeful that when I think about the work that 988 does, and being the back end for 988 or the NFL crisis line or a veterans crisis line or New York City Public School children crisis line, that they are lifelines and that people are engaging and we don't have to wait until crisis. I'm hopeful and really wanting policy to be improved around the crisis continuum and how we provide care when, whether it's mobile crisis, whether it is community-based resources, but we're wrapping people in the ecosystem, the mosaic of offerings. We're not just dealing with their serious mental illness, we're helping their family, we're addressing their social determinants, and we're providing them a member experience or a patient experience that doesn't make them do the heavy lifting. And the last thing I'm hopeful for is that we'll just continue to be fierce for the people whose voices are never heard or who are quelled or who have died by suicide because they were alone, isolated, and felt like it would be better if they weren't here. And I'm gonna get up every day and have conversations because those people don't get that chance.
That's really powerful. Anne, what are you hopeful for?
This may be a little dreaming, but
Let's dream.
I
Come on.
really hope, especially in the specialty care population, that we can come up with a framework for designating providers with evidence-based training. One reason I was drawn to Brightside for crisis care was the CAMS care model. I'd like for that to be mainstream, that we know when we're looking for a provider that treats a certain specialty condition, that that kind of designation, that competency, that experience is somehow framed or kind of systemically kind of displayed, so that lay people, providers, insurers, we all know kind of this is the type of provider for you. I think that's a challenge, but I really think that the digital healthcare companies have really been bringing us along, and there's hope to see that sometime.
Brad?
I'll make mine quick. I really think that the biggest thing we need and that I'm hopeful for is continued support and funding for Medicaid and exchange. Right? The most vulnerable populations here really need to be able to get care within insurance. And so from a policy standpoint, to me, that would just be my number one priority over this next period here.
Caroline, I'll have you round out this question about hope for the future in ways that policy might be able to support our specialty population needs.
Thank you. One thing before I answer that, and Brad alluded to it, it takes months to become a Medicaid provider. Why? Why can't we simplify that process? So just as an aside, that's something, again, on a policy level we need to think about. My hope for the future, yesterday afternoon I had the chance to really geek out with another psychiatrist talking about brain science and genetics and where things are going with our field. And as you go down a path thinking about back to cancer, we know, down to specific cell types and gene types, what therapies are going to work and what the prognosis is. The future needs to bring that into mental health also, and it's starting, it's getting there, but we have a long way to go. And unlike probably any other field, to the degree that science mashes up against social determinants, I think looking at where the future addresses all of that holistically is going to be incredibly exciting to watch. Just go look in Nature or Science or name your journal, but there's a lot of really cool stuff happening. So I'm excited about that. And then the second is just bringing models of care that further help us do mental health on a public health and population health basis.
Great. So are there any questions from the audience? Would you please step up and use the microphone and introduce yourself? Thank you.
Tanya Grant. I'm from Claritas in Nashville, Tennessee. So this question is mostly towards Brad. Like, how do you build a business around these rate fee reimbursements that don't work with what you have to pay to your therapist? And when do you think your wish gets granted from a standpoint of policy changes?
Great question. So yeah, I think you're alluding to just the gap between average reimbursement rates and what therapists really should and deserve to get paid in the market, leaving not a lot of margin for a business. For us, it's about having diversified business lines so that we can kind of average that out into other business lines, but also using an iterative cycle of being focused on demonstrating results and impact. Right? My belief is that those rates are low because payers have never really seen an ROI. Right? If we think about payers as rational financial actors that want to align clinical and financial incentives, they want to see an ROI. And our industry has never measured outcomes, and so they've never had the opportunity to have an ROI. It's going to take time to break through that paradigm, but as providers, we have to take the responsibility to raise the bar for ourselves, deliver better care, demonstrate outcomes, and demonstrate the ROI to payers, and work together with them to get those rates closer to what we would think of as market.
Thank you. All right, we'll come over here.
Hi, thank you. So there's only one...
Can you please introduce yourself?
Okay, I'm Rachel Strife. There's a group called The Angry Moms. There's only one medication that has an FDA indication to prevent suicide, and that is clozapine. It's also the only medication that works for about 30% of psychosis disorders. I have 2 family members on clozapine. Only 5% of people who need that medication are able to access it because there's a weekly blood test involved. And it's pretty difficult to get a psychotic person to do a weekly blood test. I've had to pay out of pocket for a finger stick device so that my family members can use clozapine. Our hospitals don't have this device. Some of our clinics do, but many don't. This, to me, is a very obvious innovation that would facilitate the use of clozapine. Why isn't this covered by our payers? Why isn't this covered by Medicaid? It's not that expensive. It's less than the cost of a single monthly injection. That's my question.
Thank you.
We pay for glucose meters for diabetics. Why aren't we paying for this technology for our sickest psychiatric patients? Thanks.
I'll
And
take it.
Caroline? Okay.
Yeah, I'll take it from a perspective of treatment. So clozapine is an amazing medication and is evidence-based for psychotic disorders. A couple things come into play. It's an older medication, and when it first came to market, it came to market under the REMS programs, which require the kind of monitoring that was just discussed. The science today is leading toward the REMS programs are perhaps no longer needed for this, and the weekly finger sticks or blood draws are no longer needed because the risk of low white blood cell counts that came along with clozapine are not as pervasive as what once was thought. And so I think the first part of that is there is a huge push with the FDA to get this drug out of the REMS programs, and so many of us are working on that to make that whole blood draw situation go away. The second is I don't know why those finger sticks aren't paid for. Medical devices, if you will, go through separate review processes at health plans, typically not by the behavioral health teams. It's like pharmacy is over here and devices are approved over here and BH Care is approved over here. So it's, I think, on us to talk to health plans and ensure that we're aligned that anyone who is on clozapine should be able to have access to the finger sticks like you're talking about. I'm still a clinician. I work at an FQHC. We often have to send visiting nurses out to homes to do that. It's really challenging, and I thank you for bringing that up.
All right, I think we have time for one more quick question, and then I'm going to wrap up.
Hi, I'm Georgia Hoyler-Haynes. I'm a VP of Clinical Product Strategy at Equip Health, which is a virtual eating disorder provider. I had two questions, but I'll just choose one. So Carolyn had mentioned this concept of a super DRG and trying to standardize around episodes of care. I think that sounds like a fabulous goal. I'm just curious on a more practical, near-term level if there are actually any work groups or policy, legislation or anything that's aimed at working towards some kind of standardized model like that for SMI.
No, not that I'm aware of. I don't know if others of you are in this
Perhaps
area.
the Meadows Institute could help.
But I
Great,
think that's a good
thinking about
future
it.
path. The place to start is with trying to get a CPT code. And Christina, your CEO, and I have been talking about that. There are other organizations who are trying to get specific CPT codes for certain kinds of psychotherapy, like dialectical behavioral therapy, so we can tell that that evidence-based care is done. So I think we have to start there at a minimum while the bigger policy work gets done.
Great, thank you.
Do I have time for a follow-up or no?
I think we're getting the hook.
Okay.
I'm getting the no, please don't say yes to that. So thank you all. I just want to, some things that really resonated with me as the panelists were talking, both about the challenges as well as the solutions that I think are important to highlight. We have a lot of work to do with simplification and how we help our consumers and our customers access care. And the way that we're going to do that is through collaboration across sectors and to really think about the opportunity for bidirectional learning. I think sometimes our policy folks, our payer folks, sometimes don't necessarily think about the opportunity for learning from the innovation community and from the tech community. And I think what we're seeing here today and expressed on this panel is really those opportunities for bidirectional learning by bringing people together with diverse perspectives and diverse expertise, including our patients who may be the most need of care and understanding their experience and trying to access and navigate this very complex system that we've created unintentionally over the years. The team highlighted the opportunities on the horizon to incentivize quality care and the need to actually advance measurement into our provider communities, with only 20% of providers actually doing measurement-informed care. It's difficult to understand what's working and to understand where there are places to have those ROIs. And so we have a lot of work to do there with behavior change amongst our provider and payer communities. And then I think as we closed out and looked to the future and expressed hope, the role of policy in helping to improve outcomes for mental health care is paramount. And it is important for all of us to engage in those conversations so that we can be part of the solution of the future. Thank you all for your insights, for your hope, and for all the hard work you do every day so that more people can thrive.
Thank you.